Good evening, everyone. Thank you for joining DEBAKEY live studio on our monthly cardiovascular disease prevention seminar. I'm Dr. Khurram Nasir, Chief of Cardiovascular Prevention and Wellness, and today we will be talking about CVD risk reduction with residual risk reduction, and especially talking about purified EPA. Is it really hype or hope? So, as cardiologists, I know that while statins and potentially aspirin has been the backbone of our preventive efforts, mostly over the last 2 decades, there has been a recent emphasis on addressing the residual risk, especially among those with established cardiovascular disease. Now, in 2020, we have many agents that had made their way to our options. For over the last 2 decades, of note, hypertriglyceridemia, either by itself or as a marker, has thought to be played an important role, not only in development but progression of coronary plaque inflammation, and as a result contributing to residual atherosclerosis. However, over the last 2 decades, in many clinical trials with omega-3 fatty acids, fibrates, and even with niacin, unfortunately didn't show any consistent reduction in coronary revascularization, CVD, clinical events, or even mortality, despite their ability to lower triglyceride levels. Now, things completely switched 2 years ago when REDUCE-IT showed that a high dose of purified EPA versus matching placebo demonstrated almost 25% risk reduction in the primary endpoint, including mortality. This was enthusiastically received by the cardiovascular community as a major option in our fight against cardiovascular disease. We saw a quick FDA approval, and now after that garnered overwhelming support by the guidelines. Though, like any other intervention, the adoption is catching up, but the signs are encouraging. However, at the same time, in the midst of these excitement, many issues have emerged, including disappointing results from other fish oil trials, possibly the controversy around the placebo choice in REDUCE-IT, whether the signals and imaging are more robust to explain the benefit with purified high-dose EPA. But on the other hand, we are also seeing some recent highlights on the potential benefit beyond cardiovascular disease, such as those affected with COVID. So today, to talk on all of this issue, and as I've said earlier, no topics off limit, I'm delighted and honored to have 3 VIPs to give their thoughts about this issue, starting with Dr. Deepak Bhatt, who is the Professor of Medicine at Howard School of Medicine, Executive Director, Interventional Cardiology Program, and he will be talking about Icosapent Ethyl in cardiovascular risk reduction, putting the trials in the proper context, followed by Dr. Michael Miller, Professor of Medicine and Epidemiology, Public Health at the University of Maryland School of Medicine. In addition, he's also the director for the Center of Preventive Cardiology at the University of Maryland Medical Center. And he will be talking about EPA versus DHA, and then finally introducing Dr. Matt Budoff, Professor of Medicine at David Geffen School of Medicine at UCLA, endowed chair of Preventive Cardiology, and also the program director and director of cardiac CT. And he will be speaking about some of his insights from the latest imaging trial of purified EPA. So without further ado, I will give the stage to Dr. Deepak Bhatt for his initial thoughts. Deepak.
Great. Well, thank you very much. It's wonderful to be here with all of you, and in particular at this forum. Hello to all my friends at Houston Methodist. So let me go ahead and share my slides. All right. So are you able to see my slides well?
Perfect.
Okay, good. So let me just minimize this box and get my timer started so I don't go too long. Well, thank you for asking me to speak about REDUCE-IT. Primarily, I'm going to recap the trial, but also try to put things in a little bit more of a larger context. Relevant disclosures to this talk include research funding from Ameren, paid to Brigham and Women's Hospital for my role as the REDUCE-IT study chair. And during the course of this presentation, there might be off-label or investigational discussions of the use of various drugs, including Icosapent Ethyl. So let me start off by saying there is a revolution going on in omega-3 fatty acid research. Maybe everybody doesn't realize this, but it's going on. And this is from a recent piece with Dr. Budoff and with Dr. Mason where we describe exactly why there is a revolution in terms of the biology, in terms of imaging, in terms of clinical trials. Here, what is shown is the pathway by which different omega-3 fatty acids are produced. It's a complex pathway. It's evolving. The science might be different a month or a year or a decade from now in terms of the exact enzymatic steps. But the bottom line is there's a lot of sophistication here. So sometimes physicians just talk about omega-3 fatty acids, but that's sort of like talking about hormones, and much like estrogen and testosterone are very different hormones in terms of their effects, even though chemically they're not that different. It's the same thing here, where a single extra double bond or an extra carbon chain length is sufficient to cause markedly different biological properties. And what is shown here is a conversion of linolenic acid, multiple intermediary steps, to icosapent acid, to docosapent acid, to docosahexanoic acid. And much of what I'm going to talk about will be focused on the middle one here, icosapent acid, or EPA. You'll hear others in this symposium talk about DHA or docosahexanoic acid as well. But to make sure we're all on the same page, when talking about the omega-3 fatty acid, EPA or icosapent acid, there's a lot of great epidemiology supporting associations between EPA and lower rates of cardiac events. I'm specifically going to talk about now icosapent ethyl, which is the prescription ethyl ester version of icosapent acid. It's an ethyl ester. It's highly purified. It's produced and packaged in a way that prevents oxidation. So very different from dietary supplements, very different from the drugs studied in the strength trial, very different from the supplements studied in a variety of other trials. So it's a prescription medicine, and it is unique. It is then consumed, the icosapent ethyl. It is then deesterified. It's absorbed into the lymphatic circulation, and it is reesterified right here, as you can hopefully see my cursor, in phospholipids and triglycerides and packaged for transport in chylomicrons. So that's the relationship between icosapent ethyl and EPA. You might hear them used interchangeably, but it's not exactly interchangeable. Icosapent ethyl prescription EPA was studied in the JELIS trial, which showed a significant 19% relative risk reduction in ischemic events. And a lot of physicians don't realize that this Japanese trial used icosapent ethyl, the same active ingredient that we used in REDUCE-IT. A lower dose in this Japanese population, 1.8 grams a day. In REDUCE-IT, we used 4 grams a day. But nevertheless, a 19% relative risk reduction, while only finding a 5% reduction in triglycerides. So this trial was positive, but not due to triglyceride reduction. 80% of these patients were primary prevention, 69% were women. And the benefits were consistent in the primary and secondary prevention cohorts in JELIS. So a well-done trial, 18,000 patients, Japanese patients. REDUCE-IT, you'll see, was mostly Western patients. And this is a randomized, open-label, blinded endpoint adjudication trial. So I think that's a little bit of a limitation of the trial, that it was open-label without a placebo. But for people that don't like the placebo in REDUCE-IT, well, here is a trial that was positive with the same active ingredient as in REDUCE-IT, but without a placebo, albeit randomized. That was a JELIS trial, 18,000 patients. I'm just going to mention this 241 patient Japanese study in passing. Post-PCI patients randomized again to 1.8 grams of EPA or not, open label, no placebo. And obviously 241 patients is underpowered for any clinical endpoints, but nevertheless, interestingly, there was a significant reduction in MACE, and interestingly, though of course very underpowered for cardiovascular death, a lower rate of cardiovascular death as well, with icosapent ethyl versus no icosapent ethyl on a background of statin therapy. And the p-value for that was 0.04. Again, acknowledging that it would be underpowered to look for CV death, but nonetheless interesting, 2 positive randomized trials of icosapent ethyl from Japan. Let's move now to trials that were mostly Western in the population of patients that were enrolled. The Marine trial that examined 4 grams a day of icosapent ethyl for reducing triglycerides that were very elevated, a positive trial. Anchor, looking at triglycerides that were medium elevated, not so much in a pancreatitis range. Another positive trial showing that 4 grams a day, actually 2 grams twice a day with meals, of icosapent ethyl reduced triglycerides. And then comes Reduce It, cardiovascular outcome trial. 8,000 plus patients, 70% secondary prevention, 30% primary prevention. Everybody is on a stable dose of a statin, randomized to 2 grams twice a day of icosapent ethyl versus matching mineral oil placebo. Mineral oil was chosen because we needed something that was chemically inert, as pharmaceutical grade mineral oil in the quantity of 2 cc's twice a day is believed to be. We needed something that matched icosapent ethyl capsules in terms of being colorless, in terms of being odorless. So that really limits the number of choices. One could use mineral oil, which I think would have been fine to use at these low quantities. I don't think it would have actually made a difference. But if the trial had been negative, people would have criticized us and said, why did you use olive oil? Because there people might think, oh, that it's providing benefit. We could have used corn oil. But there are some smart folks in the field said it causes harm to use corn oil. Other people said it has benefit. Again, I think at 2 cc's twice a day it wouldn't have mattered, but we decided against corn oil. The FDA ultimately did sign off on use of mineral oil. Again, pharmaceutical grade mineral oil is our placebo. We followed patients for up to 6.2 years, an average of 4.9 years, and the primary endpoint was 5-point MACE. CV death, non-fatal MI, non-fatal stroke, coronary revascularization, hospitalization for unstable angina. And it was time to first event the usual conventional way. And that primary endpoint was positive. The key secondary endpoint, heart events, CV death, MI, stroke, also positive. A 26% relative risk reduction here, about a 4% absolute risk reduction in heart events, a low number needed to treat, statistically significant. Consistency across multiple pre-specified subgroups with respect to the primary endpoint, consistency across the key secondary point across multiple pre-specified subgroups. And then in terms of individual endpoints, significant reductions in fatal or non-fatal MI and fatal or non-fatal stroke, in urgent or emergent revascularization and hospitalization for unstable angina, even death from cardiovascular causes with a significant 20% reduction. So robust reduction in the primary endpoint and in each of the individual components. We also examined total events, that is not just first but recurrent events. And here there was a significant reduction, a large absolute reduction, 500 events prevented in this population of 8,000 patients. So that's a large event reduction in absolute terms. And by our pre-specified methodology for the recurrent events analysis, the Anderson-Gill, there was a 32% relative risk reduction. We looked at it in a number of different ways. And the p-value for that was 10 to the minus 22. So a very, very robust risk reduction that withstands multiple different types of sensitivity analyses. If you don't like some aspect of the trial, some subgroup, you can throw it out and the trial still remains quite positive. Let me now briefly talk about Reduce It EPA, presented as a late breaker at ACC, that examined the correlation between on-treatment achieved serum EPA and rates of the primary endpoint, the key secondary endpoint, cardiovascular death, and total mortality, all of which were significantly lower at higher achieved on-treatment serum EPA levels. These relationships were also seen and significant for MI, stroke, coronary revascularization, and unstable angina. The relationships were consistent in the primary and secondary prevention cohorts, and were even seen for tertiary endpoints such as sudden cardiac death, cardiac arrest, and even for heart failure, which wasn't significantly reduced in the overall trial, but here in patients at the highest attained levels of EPA, lower rates of new heart failure. And I'll mention that these relationships were adjusted for things like adherence to study drug, adherence to the placebo, adherence to statins, age, sex, the usual sort of thing. So these are independent associations, highly significant correlations. And in addition to showing that EPA levels are what is responsible for the benefits we saw in Reduce It, it's also good evidence that this wasn't some sort of funny placebo effect. That is, why would there be a dose response with something if it is in fact just due to a noxious placebo? It's kind of a subtle point, but really the best evidence that our placebo was a placebo. What about looking now across trials? I mentioned GELIS and REDUCE-IT. I didn't discuss the results of STRENGTH, but that trial showed no significant benefit with 4 grams a day of a mixture of EPA and DHA in a formulation that might have been subject to oxidation and other things. And what we see is at baseline, and this is some mixing and matching with plasma and serum EPA, but that doesn't matter so much. But at baseline, the levels in the Western STRENGTH population, 21, and in the largely Western REDUCE-IT population, 26, pretty similar at baseline. But you'll see at the end of the study, or at the time the EPA was obtained in the case of STRENGTH, a level of 90, but in the case of REDUCE-IT, around 170 or so. Now let's look at GELIS. GELIS in those Japanese patients starts off with EPA levels where STRENGTH ended. And in fact, the attained levels in the GELIS trial were pretty much where they were in REDUCE-IT, albeit with 1.8 grams a day in that Japanese population in GELIS versus 4 grams a day of Icosapent Ethyl in REDUCE-IT. So the bottom line is it does seem like the 2 trials here of pure EPA, which were positive, there are correlations between the attained EPA and outcomes. And it might be a nonlinear threshold sort of response. So yeah, some patients even in STRENGTH might have gotten higher than this median or mean level, that's true. But if there's a threshold effect, that may not matter. Other folks have looked at the data from REDUCE-IT. The FDA took their own independent look, of course, from the raw data, and the advisory panel voted 16-0 to approve the label, and the label was expanded from just a hypertriglyceridemia label to include largely a population that mirrors that studied in the REDUCE-IT trial. There's been a lot of things on the way to that FDA approval. I mentioned some of the studies, such as Marine and Anchor and REDUCE-IT. Lots of different guidelines have endorsed the use of Icosapent Ethyl. Just a couple of weeks ago, the Chinese Society of Cardiology endorsed the use of Icosapent Ethyl in a REDUCE-IT-like population. Health Canada has reviewed the data and granted a broad label for Icosapent Ethyl as well. So lots of different independent groups have analyzed the data in the case of regulatory authorities right from the raw data and found the data set to be robust and the results to be compelling. Well, thank you very much for your attention.
Deepak, this was fantastic review and insights which are very critical in trying to understand the whole journey. So thank you so much. So without further ado, I will like Dr. Michael Miller to take over now.
Thank you very much, Dr. Nasir. I'm going to also share my screen, and let's do this here. All right, so I'm going to talk about some of the I guess Dr. Nasir suggested a misconceptions update in comparing a purified EPA versus the combination of EPA DHA. Well, we've come to accept the fact that that supplements over the course, I guess, of the last 2 decades have been tested in a number of trials. And those dietary supplements or prescription EPA DHA have been studied, and they've had a null effect with respect to cardiovascular events. It's been actually a fairly consistent showing. So even some of the earlier studies, and then most recently the VITAL study and the ASCEND study in the group of diabetics, looking at this combination has not translated into clinical benefit. Now, one could argue that perhaps the doses used here were relatively low. So you're looking at maybe about a gram's worth a day versus, as Dr. Bhatt showed in REDUCE-IT, 4 grams a day. We were looking at a non-hypertriglyceridemic population. So there might have been elements here that may have perhaps persuaded us that we were not we're not showing the right group of patients. And perhaps more importantly, too, as we'll talk about, is that all these studies use a combination of EPA DHA. Now, I want to talk about, or just mention at least 2 studies that were presented and published simultaneously last November at American Heart. One was the OMEMI study, looking at elderly patients taking a combination of EPA DHA, followed for about 2 years. And that study was negative. The strength study was the second study that looked at 4 grams of a combination of EPA, DHA, carboxylic acid, and a cohort quite similar to those in REDUCE-IT in that they were at increased cardiovascular risk and were hypertriglyceridemic, good sized population, and a primary outcome, the traditional MACE measures. And the evidence was that it was, again, a null study. So no difference between the groups assigned to either the combination of EPA, DHA versus placebo. And this is just, again, showing you that no difference over the course of about 5 years. So what have we learned from the omega-3 trials, and to try to keep things as straightforward as possible? Supplements and low-dose EPA DHA has not been shown to reduce cardiovascular risk. Intermediate dose EPA DHA, as shown in OMEMI, did not reduce risk. And high-dose EPA DHA, again, that combination in the strength study did not reduce risk. Now, Deepak really very nicely has already shown you the JELA study of 1.8 grams in a Japanese population on low background statin doses and high EPA levels, showing pretty significant differences in events, keeping in mind that the Japanese consume a fair amount of fish. So a lot of us didn't believe that this study would garner sufficient differences between groups, but there were, both in total groups as well as in the secondary prevention group, and certainly trending in the primary prevention group. As Deepak also mentioned, that there was a relationship between on-treatment concentration and the risk of coronary events. So this is, again, plasma EPA. And the higher the plasma EPA concentration, the better the benefit in this study. As was also already mentioned, it has been demonstrated, as was presented earlier, I guess last year at ACC, on treatment EPA levels seems to be the pivotal basis for the benefits observed in the REDUCE-IT trial, both in the primary endpoint and the key secondary endpoints. So the higher the on-treatment EPA, the greater the benefit in REDUCE-IT. One of the questions that came up during the presentation of strength during the AHA study was, the question is, why was strength neutral but REDUCE-IT favorable? And again, it comes back to this issue, at least part of the explanation, maybe a good part of the explanation, is related to the on-treatment EPA levels. If we look at strength, EPA levels at 1 year was 89.6 versus Icosapent Ethyl, and then the change here was pretty dramatic in patients in the REDUCE-IT trial. So again, all in support of the notion that the higher the on-treatment EPA levels, the greater the likelihood of benefit. So mentioning the combination of EPA, DHA has not shown cardiovascular benefit, whereas the 2 studies that have evaluated EPA only, at least clinical trials, there was the study that Dr. Bhatt already mentioned, and so a study called Cherry, and then the angiographic data that Dr. Budoff will present also demonstrate that EPA only appears to show a vascular-related benefit here in cardiovascular events. Now, EPA and DHA are available in multiple forms. If it is purchased as a dietary supplement, about 50% of the 1 gram capsule. That's actually pretty generous. Often it's only 30 to 40% of the capsule contains DHA and EPA, and a lot of undisclosed fatty acids, including saturated fat, are comprise the dietary supplement that might be purchased in health food stores or in the supermarket. In combination, omega-3 products, again, you have the EPA, DHA, much higher percentage with only a small amount in other omega-3s. And then, of course, we have Icosapent Ethyl, which is highly purified EPA. Now, EPA and DHA have varying effects on resolvins. These are generated molecules that have anti-inflammatory properties. EPA generates E-series resolvins, DHA D-series resolvins, and so they both appear to have some anti-inflammatory properties. EPA appears to be better with respect to inhibiting or reducing oxidation of B-containing lipoproteins. EPA also has reductions in cell membrane fluidity, which may have benefits with respect to cholesterol crystals. And DHA appears to have the opposite effect. So there may be some pro-atherogenic characteristics of DHA that may perhaps attenuate the benefits when used in combination with EPA. This is a study that Preston Mason did a few years ago, looking at EPA, DHA on oxidation with small dense LDL, LDL, and VLDL, and looking at EPA has the lowest amount of the most antioxidant effect. DHA and vehicle of similar, both with small dense LDL as well as LDL particles and VLDL. So an antioxidative effect on EPA that is pretty pronounced in vitro. There are also contrasting effects of EPA and DHA at the level of the cell membrane, in as much as EPA appears to very nicely fit in, conform in the phospholipid bilayer, and appears to have some membrane stabilization properties, whereas DHA 22 carbon versus 20 carbon appears to maybe affect lipid domain changes, as well as have some less structural or membrane stability. EPA has also been shown to have effects on vascular endothelium. So there's an increase in endothelial function, greater nitric oxide bioavailability, reduction in inflammation and plaque growth. And I think Dr. Budoff will talk more about this. And EPA also has reductions in oxidized LDL and monocyte adhesion with entry into the arterial wall. So taken together, EPA has a number of effects at both the cellular level and that with physiologic effects as well. So if we look at lipid therapy on the left and CRP levels on the right, statins, as you know, have nice effects on CRP, as does EPA. Mild to moderate effects, and the combination appears to have greater effects. The combination of EPA and DHA neutral, ezetimibe and statin also have nice effects here. So when we think about the various influences of therapies that are available to us, we note that several combinations here may have better effects than other combinations. So in this relatively quick review, there are distinct differences between the omega-3 fatty acids, EPA and DHA, differences in membrane stabilization, activity on oxidized LDL is different, effects on biomarkers such as CRP are also different. And dietary supplements, very commonly used in the United States, of course, have not shown benefit in contradistinction to Icosapent Ethyl. Of course, these dietary supplements generally consist of the combination of EPA and DHA. And with that, I will stop here. Thank you very much.
Mike, thank you so much. Clearly, what I've learned is not all fish oil are created equal. And that's kind of a major controversy that seems to happen among, well, this is a fish oil, EPA versus small EPA DHA combination over the counter. So thanks at least clarifying some of the issues. Now, Matt, welcoming Matt, my friend for the last 20 years, and presenting data, whether the CVD reduction that we have seen in Reduce It, can it be explained a bit by plaque changes? So Matt, please take over.
Thank you very much, Khurram, and certainly a pleasure to be here with everybody, at least virtually. So I wanted to just build upon what you heard about from both Dr. Miller and Dr. Bott. This is my disclosures. So you've already seen this in some version, but there's a lot of effects that we know now that we've been able to demonstrate. A lot of this work has been done over the past decade or so, but a lot of information about atherosclerosis and how it's affected by EPA and Icosapent Ethyl. On the left, we have the oxidation you've heard about and the effect on LDL cholesterol. In the middle, we just heard nicely from Dr. Miller about the anti-inflammatory effects that can calm the cytokines, perhaps decrease macrophages turning into foam cells, and penetrating into the intima. And then finally, the atherosclerotic pathway being affected with less plaque progression, less plaque rupture, and less thrombus formation. So let me show you what we know about both the EPA pure product and then the combination of EPA plus DHA. So there have been a number of imaging studies. This is one of them, a small study published by Dr. Nishio in 2014, looking at 23 patients in the EPA plus statin group and 26 patients in the statin monotherapy group. Again, as Dr. Bott described, no placebo used in these Japanese studies, but you can see on the left fibrous cap thickness increasing more significantly under the effect of combination of EPA plus statin. This is that 1.8 gram dose that you've heard about, used commonly in Japan. In the middle, you can see the arc of lipid goes down. So again, these are all well-validated markers of vulnerability. And you can see the lipid arc decreases more, about twice as much under the effect of EPA plus statin as statin monotherapy. And similarly, the lipid length also decreases significantly. And all of these, despite a relatively small study, were robust differences. By adding EPA to a statin, and maybe as was described by Dr. Miller, getting that combination effect that you see when you put these together. That was followed by a larger intravascular ultrasound study called CHERRY. The CHERRY study was a randomized multi-center trial. Again, non-blinded. They don't use placebo in these trials, but 193 patients randomized, undergoing, at the time of percutaneous intervention, undergoing intravascular ultrasound, and then randomized to pitavastatin 4 milligrams in both groups, and then one group getting EPA 1.8 grams a day added, and one group not getting that dose added, with a follow-up intravascular ultrasound 6 to 8 months later. What you can see here is the change in total plaque volume, more significant under the influence of pitavastatin plus EPA. On the right, you can see the changes in total atheroma volume. Again, no significant change with pitavastatin monotherapy, with a slight trend towards less plaque on follow-up, with significant reductions as both compared to baseline and compared to pitavastatin monotherapy when you use combination therapy. So we see regression of atheroma under the influence of combination pitavastatin plus EPA. They also looked at rate of plaque progression, how many patients had plaque regression, and you can see a significantly larger regression group in the EPA plus statin group in this CHERRY study. So that was followed by a study that we performed looking at CT angiography. CT angiography, as you know now, gives us a nice quantitative look at the total atheroma burden. We can see all of the coronary segments. We can do a baseline study and use quantitative software to measure plaque atheroma volume, and then do a follow-up study to look at those same components. And it breaks down into dense calcified plaque, low attenuation plaque or necrotic core, fibrofatty plaque, and fibrous plaque that can all be quantified over time. So using that concept of serial CT angio, we performed the EVAPORATE trial. It was meant to be a parallel study to the REDUCE-IT trial. So the entry criteria are similar: age, triglyceride values, LDL, all similar. Patients were randomized to the same randomization, icosapent ethyl 4 grams or a mineral oil-based placebo, and followed up. We had an interim scan at 9 months, but they basically had a CT angiogram at baseline, 9 months, and 18 months, with a goal to determine whether icosapent ethyl will reduce plaque progression as compared to placebo in statin-treated patients. So all patients on a statin, LDL is controlled, and then randomized to 4 grams of icosapent ethyl or placebo, and followed in a double-blind placebo-controlled randomized trial. This was the primary endpoint of the 18 months. This was presented at the European Society of Cardiology meeting this past year and published in EHJ at the same time. And you can see the in red, the placebo group. So these are on statin therapy. These were not LDLs achieved of 50 or 45. So these are largely diabetic populations or metabolic syndrome patients with elevated triglycerides. So we expected some plaque progression, and you can see some plaque progression in all of the red bars with placebo being added to statin. And then when combination therapy in blue, icosapent ethyl plus statin, you can see regression of atherosclerosis. And the p-values at the bottom represent the differences between the combination of icosapent ethyl plus statin versus placebo. Our primary endpoint on the left was low attenuation plaque. We thought that given an anti-inflammatory approach, as well as our ability to reduce the lipid core, that we would have a more profound effect on low attenuation plaque, the really vulnerable plaque components. And it was significant with a p-value of 0.006. And you can see fibrofatty plaque, fibrous plaque, and total non-calcified plaque, all significantly reduced. The only one that did not achieve statistical significance, but had a strong trend, was calcified plaque, which did not go up in the icosapent ethyl group, but did have some progression under the influence of placebo. So then we presented some data to look at, this is a study that we presented with Dr. Bott and others, looking at histology based on CT. So this is a plaque characteristics. This Lucid Bioimaging Incorporated company out of Boston was able to analyze the data in a blinded manner, looking at lipid-rich necrotic core, fibrous cap thickness, and intraplaque hemorrhage, using a program called VascuCap. So this is a new or still under development analysis to look at some of the plaque characteristics, kind of trying to emulate what we can get from some of the more invasive techniques using CT. And what we saw, this was on the 9-month scans, that patients on icosapent ethyl had decreased wall volumes as compared to those on placebo, -7 millimeters cubed versus a positive 28 in the placebo group. Decreased lipid-rich necrotic core, similar to our overall analysis, but using different software. reduced intraplaque hemorrhage, and increased cap thickness, all of which would suggest a migration of atherosclerotic plaque to a more stable phenotype. So when we saw some of those robust benefits that Dr. Bott described at 11 months for revascularization, we're starting to see plaque stabilization by 9 months in the EVAPORATE trial using Icosapent Ethyl. So looking at these studies and sub-studies compared with placebo, Icosapent Ethyl significantly reduced plaque components, including vulnerable or low attenuation plaque. We had an early effect at 9 months with sustained and increased significance by 18 months. And we now have a nice pairing of reduce it, looking at outcomes, and imaging, the EVAPORATE trial, demonstrating consistent benefits of Icosapent Ethyl on both outcomes and plaque reduction using similar entry criteria, similar doses of therapy, and similar treatment algorithms. So let me just finish up with, and I'm not going to go into this because I know this was covered by Dr. Miller, but there is a study of EPA plus DHA using coronary CT angiography. This was recently published, and you can see 285 patients with stable coronary disease on statins randomized to an omega-3 ethyl ester, but this time a combination product with 1.86 grams of Icosapent Ethyl and 1.5 grams of DHA, or followed with control, again, a Japanese study without a placebo arm, but high dose DHA EPA versus no additional therapy for 30 months, so a long study. They looked at CT angiography, and these are the primary endpoints. You can see 5 different components assessed: fatty, fibrous, non-calcified plaque, and total plaque, and none of them were significantly different under the influence of omega-3s versus control groups. So no significant difference over time or overall in a large and long study demonstrating that DHA plus EPA does not have the same effects on atherosclerosis that we saw in several trials. So in summary, this imaging data supports the marriage of clinical trial results such as JELIS and REDUCE-IT and imaging, the trial from Nishio, the CHERRY study, and the EVAPORATE trial, demonstrating consistent benefits of EPA on both outcomes and plaque reduction. They highlight early and substantial impact on the at-risk population. And conversely, combination EPA-DHA has no positive effects on outcomes or atherosclerosis. And we already heard in great detail that EPA plus DHA does not improve outcomes, even at similar doses to what was studied in that paper that I just presented. So I'll stop at this point and thank everybody for attending the conference today.
Hi, thank you, Matt. This was fantastic. I think this is going to be the future where you're going to have a lot of imaging studies going along with the clinical trials, maybe some early phase 2 insights before moving into the phase 3. But I can tell you there has been significant interest from the audience out here, and I'm copying a question right now. So Sergio and Emmanuel Kaiser is asking that, would you consider cautioning prescribing Vascepa in patients in sinus rhythm and left atrial enlargement, considering the increased risk of atrial fibrillation that was documented in all the different omega-3 trials? Deepak and Mike.
Or go ahead, Mike, if you like.
There, at least in the REDUCE-IT study, there was no, I'm not aware that there were cases, new cases or incident atrial fibrillation that arose as a result of Icosapent Ethyl. So the patients who had AFib had a history of chronic AFib, and so I would not hesitate to use this agent in a patient who fit the criteria, despite having some degree of left atrial enlargement and normal sinus rhythm.
Yeah, I agree with that bottom line. That is consistent with the labeling of the drug. There's no, black box warning or something for folks that actually have atrial fibrillation. So it's a good question from Dr. Kaiser. But, in someone that just has an enlarged left atrium, I wouldn't really factor that into the decision whether to use or not use Icosapent Ethyl if there was otherwise an indication. But of course, in any patient with left atrial enlargement, you want to be cognizant of the fact that their risk of AFib in the future is, higher. But that's a separate issue. And likewise for the patient with atrial fibrillation, there was an increased risk of hospitalization for atrial fibrillation in the REDUCE-IT trial, in that about 10% or so patients with AFib. And the patients without AFib in their history, there's a very, very small increase in absolute terms there as well. But predominantly the increase was in folks that had known atrial fibrillation in their history. And even in that subgroup of patients that had atrial fibrillation at baseline, a pre-randomization subgroup, or those patients that developed atrial fibrillation in the trial, a post-randomization subgroup, those subgroups were consistent with the other subgroups that I did show, with consistent effects on the primary endpoint, the secondary endpoint, cardiac arrest, sudden cardiac death, stroke. Of course, stroke is the one we worry about with AFib, but in the overall trial, there was a significant 28% reduction with consistent findings in those two subgroups I mentioned. So if somebody has atrial fibrillation, I would make sure that the rate's controlled, if otherwise appropriate, the rhythm controlled based on just the patient's desires and lifestyle and so forth, likely that they be anticoagulated just based on good clinical practice. But that, again, it wouldn't factor into my decision to use Icosapent Ethyl. Now, if they had rapid AFib that's uncontrolled, that wouldn't be the time I'm saying let's start any sort of primary or secondary prevention therapy. There, I just get the AFib under control first.
That's perfect. So, Matt, a question to you. Historically, all the atherosclerosis plaque changes, regressions, progressions, mostly performed on IVUS studies, invasive, limited plaque volume. Now, how would you explain it to the audience who are not well aware of the differences on IVUS studies versus those done in CT? And I think so that's important critically because looking into the future, that's where we are going to spend most of our time. I think so the CTA is likely going to take over most of the CTA of the IVUS trial. So how would you educate our viewers on how to interpret those studies? Because I think so there was some controversy when the final evaporate trial came in. Folks weren't too used to the parameters. So how would you explain them how to look forward to this?
Yeah, CT has certain advantages and disadvantages compared to intravascular ultrasound. If you think about a spatial resolution, being inside the artery is going to be better, and intravascular ultrasound can see the plaque with greater detail. However, it's limited to one or two segments of the coronary tree. Conversely, with CT, we have slightly less resolution, but we can see the entire coronary tree. So we still get a total atheroma volume. It's just a slightly different value. It doesn't represent one or two segments of disease. It represents a 21 segment model in the coronary tree. So, you're giving up a little bit of spatial resolution. You're gaining a lot more visualization of the entire process. And of course, moving from a very invasive process to a very non-invasive process. I wouldn't be able to have done the evaporate trial with IVUS even if I had 10 times the amount of funding, because we studied patients who were not going to the cath lab for an acute coronary syndrome. We studied patients who were stable. So it would have been unethical to do the first cath and IVUS, much less a follow-up. So we can expand the patients we study, we can expand the number of segments and the amount of plaque we can see. And I think that you end up with a similar result in a much lower cost, much safer environment for the patient.
Yeah, I couldn't agree more. The best part was the signal was almost similar to what we saw in REDUCE-IT. So now the issue would be around the placebo. Now, question for you, Mike. I saw that the strength investigator made sure to rather suggest versus placebo versus corn oil. So are they making an assumption that there is something with the placebo of mineral oil that we should be concerned about with slight elevation in CRP, LDLs, lipid dysfunction? Does it matter? Of course, from an FDA perspective, that's never been an issue, but what would you suggest to someone raising that question?
Well, you know, in the New England Journal paper, looking at the placebo group, those that had a small degree of elevation versus those that didn't, there was really no difference in outcome. You take this information, you look at other studies that have used mineral oil, and I actually think Deepak published a paper recently. He was a co-author in a paper that looked at a whole bunch of different studies that used mineral oil. There's really not a whole lot with respect. A lot of those studies didn't show any differences in the LDL values. The bottom line to me was that you look, even if you believe that the mineral oil played a role here, it couldn't contribute to more than a couple of percent anyway. And then, of course, you have the background of looking at some of the other studies that we spoke about, including Jealous, where no mineral oil was used. Cherry, no mineral oil was used. And some other studies have not, in the absence of mineral oil, you still see the benefit of EPA. So again, in totality, the evidence doesn't really speak to mineral oil playing any significant role at all.
Deepak, do you have any thoughts on this?
Sure, I think everything Mike said really makes a lot of sense, and I guess I'd add a couple of different points. So, you know, of course, the FDA looked at this and do sort of their worst case scenario analysis that if, you know, all the changes, all the differences between LDL and CRP between the two randomized treatment arms and reduce it were due not to benefit from the Icosapent Ethyl, but due to, you know, a negative effect from the placebo, and imputed what sort of cardiovascular, you know, risk would be induced by that. You know, at most, as Mike said, you'd be 1, 2, 3% or so of a 25%, you know, risk reduction time the first event to 32% risk reduction in total events. So I don't actually believe that there was any effect, but even if one believes that, it's still a small change in biomarkers. In fact, even the change in triglycerides we saw in Reduce It didn't account for, you know, the benefit in the trial. It was the increase, the substantial increase, and it appeared to be above a certain threshold increase in EPA that accounted for the benefit. And you know, strength, it's interesting. I mean, there's a significant 19% reduction in triglycerides. Well, why didn't that biomarker change correlate into benefit? It's because, you know, biomarkers only get us so far. I mean, you know, that's why we designed Reduce It as a cardiovascular outcome trial. And Jealous, you know, there was a trivial reduction in triglycerides, but there was still a reduction in ischemic events. So I think, you know, sometimes we get overly fixated on biomarker changes that are relatively small, or even when they're larger, may not necessarily correlate to clinical events. You know, Mike's right. We published in the New England Journal of Medicine supplement, but also in the EHA over the summer, just some data that had been presented at the FDA as well, looking at patients in the placebo arm that had increases in their LDL, patients in the placebo arm that had increases in their CRP. And if for some reason you just don't like that happened, you can throw out those subgroups of patients and look at the ones that didn't have such changes. And the trial still remains robustly positive. It doesn't really change the effect size or anything in any appreciable way. So, and you know, over the summer, the Reduce It Steering Committee put forth some data at ESC. It hasn't been published yet, but it was presented in abstract form looking at different statin types in terms of lipophilicity, different statin drugs and doses and things. And, you know, across the board, there was a benefit of Icosapent Ethyl versus placebo. So if somebody was thinking, oh, the placebo is interacting with drug absorption or this or that, we could find no evidence of that at all in the trial. And, you know, during the course of the trial, of course, the steering committee, you know, Dr. Miller, myself, others were blinded to the data, but the Data Safety Monitoring Board was keeping an eye on things like biomarkers and in correlations with clinical events, and is anything funny happening? And really they didn't see anything that was worrisome to them at all. So, really it comes down to the totality of evidence, and I think it's really quite robust with several, trials, the major ones being JELIS and REDUCE-IT, complemented by the great mechanistic studies, CHERRY by the Japanese, and EVAPORATE by Dr. Budoff. So it's 4 separate trials, 2 with placebo, 2 without placebo, all randomized, different sets of investigators, and all the EPA trials are positive. And that's not even including some of the smaller imaging studies Dr. Budoff mentioned, or the NASAKA study that I mentioned. It's just 241 patients, but randomized study. So every EPA trial that's been randomized has been positive. I should say every Icosapent Ethyl trial that's been randomized has been positive. So, I think the likelihood of it just being a spurious result, is incorrect. And I think a fundamental issue is a lot of physicians who believe there has to be a second confirmatory trial, which is not a crazy thought, forget that JELIS occurred, or even if they remember JELIS, are unaware of the fact that it's the exact same active ingredient, Icosapent Ethyl. The doses are different, the brand name drug is different. We studied Vascepa in REDUCE-IT, Epidemiology was studied in JELIS, but the active ingredient, is the same. So I think it's a very consistent story. And the final 2 points I'll make, one I already made, the EPA analysis from REDUCE-IT is useful for the drug, but it's also useful for the placebo, because why would there be this noxious placebo effect causing the results of REDUCE-IT, but there's a dose response with the EPA levels as a result of giving a purified EPA, Icosapent Ethyl. It actually entirely discounts the possibility of some noxious placebo. It is a bit of a subtle argument, but anyone that thinks that through will see that. And the final point I'll make is, we did look at safety and tolerability of the drug versus placebo and REDUCE-IT, like we do in every trial. And the safety and tolerability overall, yes, there was more AFib and bleeding with Icosapent Ethyl, but if we look at it overall, identical rates of safety and tolerability if we look at treatment emergent adverse events. So that means the drug is very well tolerated and very safe. That's great for the drug. But the other way of looking at it, which I think is a bizarre way of looking at it, but for people that are concerned about the placebo, I'd say, well, the placebo was as safe as the drug. So, again, if the placebo was this really noxious sort of substance, it would be really weird that it's just causing bad cardiovascular events, that it's raising cardiovascular death, because then we have to say that pharmaceutical grade mineral oil at a few cc's a day is raising the risk of cardiovascular death, because in REDUCE-IT we saw a significant reduction. And I think at that point it's a fine sort of thing to debate, to just generate controversy or fun at a symposium or a presentation. But I think on a common sense level, there's just so much evidence to suggest that what was seen in REDUCE-IT and JELIS and CHERRY and EVAPORATE, it's the real deal.
No, this is fantastic. Anyone who is still skeptic, I would advise them to go back, and everything's recorded and you can hear this back again, because this is exactly the issues that we need to address in these type of conversations. So, Deepak, you also mentioned about the triglyceride role. Of course, what we've seen in REDUCE-IT, the benefit was much more than anticipated in reduction in the triglycerides. Also, a practical question that happens in clinics. You see patients who may be eligible with triglycerides of 155. You advise weight reduction, exercise, dietary component. They come back in 1 month's time. Now their triglycerides are 110. In my view, they're still candidates for Icosapent Ethyl. So how would you put these things together in clinical perspective when, of course, there is a labeling, but also we are looking at, is it time to move beyond the triglyceride cutoffs?
Yeah, it's a terrific question, very insightful. And I guess I would say, first of all, it's a broad label. There's lots of different guideline endorsements, and I'd say the patients where it's completely, in REDUCE-IT inclusion criteria, consistent with the label, make sure those patients are getting treated, because I think the majority of them to date still are untreated, as is often the case with new therapies. It takes years for them to permeate into the community practices, but that's unfortunate that happens. But I think the robustness and the strength of data here hopefully are enough that practice will change more rapidly in the years to come. But going beyond where they're labeled indications or the trials specifically studied them, I would point out that in REDUCE-IT, about 10% of the patients had quote unquote normal baseline triglycerides if you look at the initial 2 fasting triglycerides before trial entry. And there was a similar degree of reduction as in the overall trial. Even if you look at CV, death, MI, stroke, hard MACE, not that one should look at subgroups and p-values, it was a significant reduction. So I think that it is perfectly justified intellectually to use it in those sorts of patients. And then there's GELIS, where at least half the patients had normal triglycerides. The average triglyceride on entry was about 150, and that was really even before optimal use of statins were deployed. So probably, in fact, it ended up even a bit lower than that. So those patients benefited in the trial. So I think it is true that if someone has elevated triglycerides, their risk is higher, their absolute risk is higher than someone with lower triglycerides. Higher triglycerides are worse. It's sort of like higher LDL or higher weight or higher glucose. You don't want to ever have high values of those, and higher within the range of elevated is worse. So, a triglyceride of 400 is greater risk than somebody that's got a triglyceride of, 152. But even the 152 is worse than somebody that's got triglycerides of, 50. So I think, physicians have to use their discretion if they're going to go beyond the labeling. But the U.S. labeling is pretty good. I mean, it says 150, but it doesn't specify fasting or non-fasting. So, we don't actually get fasting triglycerides unless, for specific dyslipidemic syndromes. But for the average patient coming in, we get the triglycerides whenever they show up, just for their convenience, and so they don't just have to fast, for a brief patient encounter and lab draw. So, you can get the non-fasting triglycerides, and if those are elevated, that's still a trigger point to prescribe. And I think in many respects, even though we used fasting triglycerides and reduce it, the non-fasting triglycerides are better because it's a metabolic stress test. If somebody's, postprandial triglycerides go through the roof, that's usually a bad sign. And yes, tell that person to lose weight if they have diabetes, get their glycemic control a bit tighter, and do all the other good stuff, check for thyroid disease, make sure they're not drinking too much alcohol, et cetera, et cetera. But for the majority of patients, I think the fact that they've evidenced elevated triglycerides, they've failed a metabolic stress test, and I would ramp up their therapy if it otherwise fits into their sort of a sense of polypharmacy and cost.
So, Matt, now just extending this indication, now coming to those without established cardiovascular disease, clinical and non-diabetic, but a high calcium score. Would you treat them? What's the justification? Do we need another trial based on the preponderance of the data we have, how this is such a high risk population, and how do we get that mainstream?
Well, I think that I think almost everybody would agree that a high calcium score portends a high risk for primary prevention. In the Reduce It trial, there was similar results, statistically similar results for the primary prevention cohort and the secondary prevention cohort. We didn't do calcium scores in Reduce It, but Evaporate also had a blended primary and secondary prevention cohort, and we have calcium scores in that cohort. So I think that you can just take a high-risk individual in general, however you ascertain that, and put them on therapies to lower their risk. So if they're, in my mind, I still use triglycerides as a reason to treat with a Vascepa, but we don't know, triglycerides of 120, 110, but we have great data for 135 and up. So if they're elevated, if the triglycerides are elevated and they have elevated calcium score as a primary prevention patient, I would consider that a similar type of patient to who is enrolled in Reduce It and be very comfortable adding Icosapent Ethyl to statin therapy in that population.
Perfect. So, Mike, I know we don't have a crystal ball, but I see, and I couldn't agree more with one of your review article where you said that, look, let's not treat it as a niche. This is likely going to become mainstream. And in my view, everyone at a higher risk at some point, maybe in 3 to 4 years, will see a statin, Icosapent Ethyl combo. So what would be needed from our academic community for us to get there quicker than waiting another 10 years?
Well, I think we are there. So, and it takes a little bit of time to get the message out. When statins first came on the market back in 1987, there wasn't that great uptake. The great uptake was in 1994 when the 4S study came out, and that's when cardiologists said, this really works. We know we have outcome data, and that word then got disseminated out to the primary care physicians, and then statins, took on a life of their own. So I think the same thing is here. The data from Reduce It just came out a couple of years ago, and now it's important to really get the message out. I think the study between Reduce It, Evaporate, really very consistent data. I think cardiologists really have a good feel for it. So I think there are two things. One is, number one, to get the message out so that primary care physicians and other healthcare professionals that take care of patients, nurse practitioners, PAs, et cetera, will garner this information. And the second thing, too, is really trying to get insurers to pay for it. I mean, it's still interesting that I'm still filling out prior auths for some of my patients that should definitely be on Icosapent Ethyl or Vascular, and they're not getting it. So there needs to be some way to break through to insurers that this needs to be done. And I will say one thing, but because some insurers will say no, they have to be at 150. So let's say you have a triglyceride of 135. DEBAKEY made a very astute statement, that is, we don't measure non-fasting. So if you have a patient that's hovering in the 120, 130 range, to get them up to 150, have them drink a really nice, delicious milkshake, and then measure their triglycerides a couple of hours later, and it'll get up to 150.
Well, Mike, if you were here, we would definitely would have served the milkshake. So one final question. We are a little bit above the time, but this is coming up all in our clinical cases, and a lot of discussions happening. Thankfully, over the last 5 years, we've made significant progress in multiple agents in reducing residual risk. So patient walks in, past MI, high-dose statin, LDL in their 90s on Zetia, and triglycerides 135, is diabetic. What would you push? And quick answer from everyone's thought, because we don't really the right answer. PCSK9, Icosapent, or any of the cardiometabolic drugs, or all of them. So how do you do that? How do you decide in your clinic? Some practical tips, everyone.
I always put lifestyle. You don't want to forget about lifestyle, and see if there's a possibility that we can get there. If they're a little bit overweight, even a small percentage of weight reduction will help glucose, blood pressure, as well as lipids. So I continue to hone in on lifestyle. That may not be sufficient, of course, and then it's a matter of what are you going to push, what are insurers going to pay for, is the patient willing to take another medication? So I think a lot of this is highly individualized, and I'm a big fan, of course, of omega-3, of Icosapent Ethyl, Vascular. So I would try to get that patient into that milkshake and get them onto that.
Yeah, I agree with that wisdom. I would also, talk to the patient and see. Some patients don't want to be on more medicines. I can respect that. And there I would push lifestyle even harder, give them, the option of a plant-based diet, which I think is the best approach. I would give them that option even if they weren't really wanting it, but it'd be up to them whether to accept that advice or not. Then beyond just lifestyle, in terms of diet and exercise and weight loss, I would want to ramp up the therapy on that high-risk patient, but it depends, again, on their tolerance for polypharmacy, their costs that they might have to pay out of pocket, and, whether they're willing to bear that or not. So it depends on a bunch of things. But putting all those patient-specific issues aside, if they're already on, the patient, I think, was maxed out on statin and even on ezetimibe, I would, that sort of patient with a reasonable LDL control, I would start them on Icosapent Ethyl. But having said that, I wouldn't be averse to starting them on a PCSK9 inhibitor either, at the next visit if their LDL was in a range that I thought was suboptimal for their level of risk. But once more, depend on their desire and tolerance for injections and so forth, the copay they might have to to deal with. And then you mentioned cardiometabolic drugs. I mean, I'm a big fan. If the patient had diabetes, I can't recall if you said that one did, but if the patient had diabetes, I would see, is there any way I can get them on an SGLT2 inhibitor, and if there's still room to play in terms of hemoglobin A1C, in terms of tolerance for additional drugs, in terms of cost and copays, GLP-1 agonist as well. So, there are a lot of things I like to do. I think doing it all at once could be problematic, because if there's a side effect, then it's hard to know what to ascribe it to. But on the other hand, I think just, see you next year can be dangerous, because, events can in fact accrue even in the stable outpatient. So I'd want to see them back and, ratchet up their pharmacotherapy, again, assuming they're on board with that approach.
Matt, final.
I would just say, I would just say, just keeping it from a lipid perspective, if, they're on a statin or they can't take a statin, look at their lipids. If it's primarily an LDL problem, I'm thinking more, PCSK9 or bempedoic acid as an add-on. If it's predominantly a triglyceride problem, their LDL is under control, I'm going to go to Icosapent Ethyl. I think of diabetes as a separate problem on a separate problem list. So I would think of that separately and not make it compete with the lipids, just like I wouldn't say, oh, your blood pressure is high, but your LDL is out of control. Should I start an ACE inhibitor today, or should I start a statin? I would probably start them on both. So I don't let the diabetic drugs overlap, but I think, as Dr. Bott had mentioned, very importantly, we have to think of cost, we have to think of compliance, we have to think of tolerability of polypharmacy. But I'm a big fan of both of the SGLT2s and the GLP-1s, depending on the scenario for a patient with diabetes, as an additional add-on therapy.
Well, Deepak, Mike, Matt, thank you so much for joining. The take-home message really for the audience is all fish oil are not created equal. Icosapent Ethyl has clearly demonstrated the mechanism why it's associated with reduced reduction. There are more than a single trial, significant improvement in cardiovascular events as well as all-cause mortality, and fantastic insights from Matt's group really tying together how atherosclerosis reduction and regression can fit into the story. It's wholly supported by our current guidelines. Most of the patients that would meet criteria, I think, so we should start having these conversations. Of course, in 2021, we are blessed with many options in treating residual risk as compared to 10 to 15 years ago, where we were stuck mainly with statins and aspirin, although we weren't doing a great job with that too either. But with this comes some complex issues, more need for shared decision making. I think so everybody needs a more lifestyle intervention and hopefully a healthy milkshake. Thank you so much, everyone. Take care.
Great. Thank you very much. Bye, everyone.
Be well, everyone.